Specifically here, when we talk about the innovation in care, Australia, like many developed countries, faces a growing ageing problem with a rising incidence of chronic disease, and as this demand for appropriate healthcare increases, our healthcare services come under greater stress. And as most of you from the healthcare industry would know, over the last 5 to 10 years, the government's response and the healthcare industry's response to improving performance has been largely based upon putting more human capital into the system. And of course that model's not sustainable. I think when you look at the quality of our healthcare, you think about access, availability, quality and cost, we rank highly around the globe, and I think the challenge we have is how do we maintain that? And the answer can't be continue to throw bodies at it. We've got to be thinking about things that are different, and the panel this afternoon will be talking about that.
We'll kick off, and Steve gave a little bit of this intro already, which is that we live in a country where we have a great healthcare system. We have one of the longest life expectancies in the world. Access to healthcare is fantastic, but like many other developed countries, we're facing changes in terms of the way that healthcare needs to be delivered. We have a healthcare system that was largely built to treat acute health issues, but is increasingly faced with an ageing population and better treatment of acute diseases, which is leading to a larger demand in terms of chronic, dementia, etc. I'll give a couple of stats before we dive into the questions. In Australia, we spend $121 billion on healthcare, or a little bit more. It's around 9% of GDP. It's around $5,500 per person. The other point is around 11% of the Australian working population is currently employed in the healthcare sector, and it's forecast that by 2025 that will get to 20% under our current model. So we're not in a position of crisis, but we are in a position where we need to change and innovate as we go forward. And so to get the conversation started, I'd like to talk, I guess, around one of the areas that will impact the system's sustainability, and that's different models of care, different pathways of care. And John, maybe we'll start with you. You have over 30 years of experience in the area of breast cancer. You've worked tirelessly to increase access for women to breast screening services, and you've changed models in how you've looked at managing such a significant chronic disease as breast cancer. So can you talk a little bit about, your approach to a different model of care and some of the challenges you faced with that?
That's a big question.
Yeah, it is.
So I guess the traditional model of healthcare used to be doctor, power, knowledge, information, and patient across the desk. And certainly when I started in the early 80s, it was a bit like that. There was no internet, there was no information, the doctor made the decisions, and it was quite clear, certainly when I spent a year and a half or so in the Dana-Farber Cancer Institute in the US, that there was another model out there, which is the doctors surround the patient, provide team-based care in one place. And I guess I've basically spent most of my career building systems which focus on the patient or the consumer in terms of screening, but at the same time recognising that the clinician and other health staff are important people in that, and we need to empower the clinician, we need to give them information, we need to give them good IT and technology systems.
Bupa, if you haven't seen our adverts, you're probably living under a rock in the last 12 months. Find a healthier you. It's quite a significant statement, and it's exactly what we live and breathe for at Bupa. We're now moving to changing the way and the setting to which healthcare is delivered in Australia and other countries. And it's about patient-centric care. It's about, yes, acute will always be needed, but it's actually a development of things that are missing. Subacute, step-down facilities. It isn't just acute to home. There's a whole infrastructure that needs to be built if we want the change to be right. And our view is that if we can't find them, then we'll build them. We will actually build them, buy them ourselves if we have to. But that's our commitment to changing the way it's delivered.
Well, I think health innovation is probably one platform, one theme that connects pretty much every market in the world. Everyone is figuring out how do I provide, every government, every system is united on better health for more people. And so you see the race is on. I think when we look at new models of care, you have to look at India, in the sense that I think a lot is happening there, both from the entrepreneur community and just the health delivery. Cost is a huge driver. It starts there, but what people don't often realize is that it's also about the best quality. So it's not inferior technology. If ever those days were right, they're over. I'll give you an example of what I mean. This is a point of comparison that's out of the US, but I think it's relevant. So many people here have executive physicals, or you go and once a year and you have your physical. In the US, because a lot of that's out of pocket, it would cost about $5,000 to $6,000. In India, it's $100. And that's full on, all medical diagnostics, includes lunch. And you know, I think that's getting people's attention. And the fact is, India right now is a market where there is very little public support of healthcare. It's probably going to be the world's biggest consumer marketplace for healthcare. So all eyes are on India. I think what governments are doing, we're working quite a bit with the Chinese government in terms of rural healthcare, rural health delivery. We've recently set up a health innovation center in Chengdu, China. And the whole purpose of it is to bring the government with local health providers together with our technicians to figure out how do you come up with the technology that's going to work in rural settings. We're working in Saudi Arabia, another area where you might be surprised to think that it's the top priority for the government is coming up with new models of delivery. And one of the areas we focused on are new breast cancer efforts in a country where cancer is a curse because of societal and religious issues. Breast cancer is the curse of curses. And so women aren't diagnosed, and if they're diagnosed, it's basically a death sentence. And so there the government has worked with companies like ours to do new models of screening because you have privacy and other issues, and using digital and social media so that women can hide behind, if you will, a virtual avatar to ask questions that help them feel more comfortable about getting breast cancer screening. So those are three models, I think, that from maybe unexpected places that I think all eyes in the world are trying to learn from one another.
The other point, I guess, you know, this idea about consumer-driven changes and consumers, you know, social media, using avatars to ask questions, consumers demanding more information and using that to drive care. I guess, you know, Gus, maybe if you want to lead off on this, how much do you think the consumer will start to drive changes in the way that healthcare is delivered?
Let me paint utopia, and I think utopia is about 10 years away. Doctors will become and be seen to be as any other professional is that you employ, and you will do what the customer is asking you to do. I actually believe that in 10 years' time we will see total customer-driven healthcare. And the reason I say that is that our products are $84 in India, by the way. And they do have the luxury limo and the anniversary packages. We're one of the biggest insurers there now. I was also just back from Saudi, and we're running a GAP clinic, we call it, for women with breast cancer in Saudi Arabia. And it's really about the social needs and supports that they require rather than the clinical, because of the, you know, the whole thing that goes with cancer in that culture. So it's interesting that in a country, what I found really intriguing, that in a country such as Saudi, where, by the way, women are now a big part of the workforce, probably more the workforce than males are. They're 70% of our employees in Saudi. They're actually having a voice and an opinion. They can't necessarily have it externally quite overtly, but they certainly have it internally at work. And it was those people who drove us to open a cancer gaps, what they call a cancer gap club. Because they came to us and said, this is what's missing. Find a Healthier You has resonated around the whole Australian public in a way that we did not envisage, by the way. We thought it'd be good. Our marketers told it would be great. It was worth the spend. And I just sat there and went, yeah, okay, we'll see. We have been inundated from customers, from people, from your neighbours, from your daughters, children, aunties and uncles about the help that they need, and they're blowing us away. All of the things that I thought were important, honestly, yep, they're important, but they are nowhere near top of the charts. It's all about filling the gap in knowledge, choice, and what if. It's the unknown, but it's the choices that they want now. They really want to know what the alternatives are, best for them, best for their family, best for their children. How can we help someone who has cancer, who is 84 and also has dementia? They're the phone calls that we're getting. We're getting phone calls from 24-year-old girls women have had their first baby. Mum lives overseas, okay? She has no social supports. Not one person, hundreds. How do I look after a new baby? Nobody's ever shown me. It's all changed, and people are going to drive this, and we're going to drive it ourselves by purchasing, assisting, acquiring, joint venturing, whatever it is we need to do to fulfil patient-centred care at whatever cost that happens to be at. It's not at the cheapest, it's the most appropriate care in the most appropriate setting. That's what drives us, but it will be patient-centred.
I just want to say a couple of things. We've got a great health system here, having done a sabbatical in the UK recently and being on one of the UK's cancer survival committees, because they've got one of the lowest breast cancer survival rates in the Western world. We're investigating what's happening there. But number two, I totally agree with Gus. I think, you know, it's not good enough for doctors to just give advice, take a piece of the body out, the tumour out, and then, you know, the patients spend maybe 2 or 3 days in hospital these days, and then they're dumped back home without support or knowledge. The window's getting smaller and smaller, and unfortunately, still many health administrators think the hospital is the centre of the universe, and it's not. Most healthcare occurs in the community, and therefore it's important that we put end-to-end systems in place to make that work. When we did our first case of liposuction for swollen arm at Macquarie University Cancer Institute a few weeks back, and very exciting actually to see a young 45-year-old woman with a kilogram extra in her arm, to liposuct it all out. Instead of fluid, 85% in fact is fat. And we had a visiting professor, we got him to train us. This lady hasn't been able to wear a coat for 4 years. This is life after cancer. Constant reminder of a cancer. She's now bought two coats. She just thinks we're wonderful. She's been on Channel 10 News. She's been the Women's Day soon. But she was treated 6 or 7 years ago. She mentioned Professor Kevin, who I work with. She mentioned another hospital. I couldn't find her records. And we did a pre-operative MRI at Macquarie because we did this volumetric stuff and worked out how much fat and fluid there is in the arms. And the Professor of Radiology came up to me and said, John, she's about to go on Channel 10, right? And she said, John, I'm worried about her shoulder. And this lady had like 10 positive nodes, high risk for metastasis. There's something in her right humerus, could be metastasis. I'm a bit worried. Now, what do you do? When do you tell this lady? It was an experimental MRI. So anyway, it suddenly clicked to me, maybe she's got an Odyssey record. So I went into Odyssey, looked up her record. She had a record there since 2004. This was a system that we designed with systems engineers using the clinician's workflow process, quickly got in, sorted it, found her bone scan from 4 years ago, click, there it is, unchanged in the uptake in the left humerus, consistent with bone infarct, okay? I knew immediately she had something there that was benign that is unchanged. So there's all this rhetoric about wasting money and supply, and we're going to, nobody wants to invest in technology, but the pain that I could have caused that lady, the extra investigations, the potential biopsies, the potential readmission, it just goes on and on. The fact that I see so many patients with repeat tests, there is so much wastage in health, it's not funny.
I actually believe that GPs will never be able to be the gatekeeper that we all wish them to be, either from the lack of time that they have, the supports that they have, the complete lack of primary programs available to them to refer people into. In the absence of that, we're dreaming. So I actually believe the best place to capture the patient, if it's not at the front end through dealing with people like ourselves who will be the intermediary in getting good advice, education, information, best evidence and so on, of informing that patient. If it's not at that end, then it's at the diagnostic end. More and more people don't go straight to the surgeon anymore. They don't go straight to the specialist. The majority of people are actually going through path, radiology, there's the MRI, get that done first. It's at that point of entry we believe our focus should be. Okay, and that will probably see us entering into that field of delivery to try to change. The question would be, well, why would you pay for diagnostics and then people go to hospital? Well, maybe the diagnostic should be about diagnosing whether or not you actually need to go to the next step of intervention, not just the fact that we've found this and off you go. So actually change that quantum. If you do that, then you're starting to change the way in which healthcare is delivered in a more cost-efficient way that will allow for greater use of diagnostics. I think people are scared of diagnostics because they can't control the quantum. We can. We can control our spend in it by saying we will fund 100, 20, 30, 500, and that's it. And our members will go to those. But I think we can actually assist the government in changing that. And the private sector has done this over many years.
Yep.
I think that Da Vinci was a perfect example of, I wasn't going to fund 500 of them. I funded 3. I agreed to fund the rest. If you could do it at $80, I'd fund it. Okay, nobody could, so they didn't build them. Sometimes it's 4x2 to stop supply, and sometimes it's just good commercial collaboration to find a way in which patients can access it affordably.
It was a fantastic session today. I think some of the insights for me were really about the importance of collaboration and the fact that even in an environment as complex as healthcare, it comes down to how people can work together and how people can find an environment where they can innovate and they can try new things and they can have the freedom to fail and the freedom to do things differently. The future of being patient-centric was a huge theme of the discussion today. And there's a couple of insights I sort of had around that. One is really the fact that it's the patient that will draw the use of technology into healthcare and will change the way that healthcare is delivered. And secondly, the fact that there will be such a big challenge and an affront, not an affront, but a challenge to healthcare professionals when the patient is in charge. And I think some of the comments made by the panelists around, in the future, doctors will be like any other professional. They'll need to do what the patient wants.